All right, I'll start at the beginning. The weather, no, I promise I won't. Okay, so welcome everybody. It's really a pleasure to have you all here tonight. This is, as you know, the Maurice Strauss Distinguished Public Lecture, and we're extremely grateful for the support that Mr. Strauss has given this program to bring these great speakers to the entire community. And as you know, many of you know Maury passed this past year, but his family sometimes tries to come out as well. So anyway, we're very thankful to them. Before I introduce tonight's speaker, as you know, I always like to put in a plug for the next speaker of the series. So I'll mention that to you. The next talk in this series will be on March the 6th. And the speaker is Dr. Marion Betts. Dr. Betts is Professor of Epidemiology and Emergency Medicine and Deputy Director of the Injury and Violence Prevention Center at the University of Colorado School of Public Health, a member of the National Academy of Medicine. And she'll talk about suicide by firearms in the United States, a collaborative path for prevention. A topic of great concern to our society these days. It doesn't get talked about enough as far as I'm concerned, so hopefully many of you will be here for that. I also remember I'm supposed to put in a plug before I introduce the speaker for Brain School, which will be coming up. If you were next door, you may have picked up one of these little cards. It's coming up on March the 10th. We have a fantastic group of speakers focusing, no pun intended, as you'll see in a minute, focusing on focused ultrasound and the various uses of focused ultrasound for therapeutics and intervention and so forth. So hopefully many of you will be here. Okay, it is now my great pleasure to introduce this evening's speaker, Dr. Vivian Ho. Dr. Ho is the James Baker III Institute Chair in Health Economics at the Baker Institute for Public Policy at Rice University in Houston. She did her undergraduate work in economics at Harvard and then received a graduate diploma in economics at the Research School for Social Sciences at the Australian National University in Canberra, Australia. And then from there, she did her Ph.D. in economics at Stanford University. She then went on to serve in a variety of faculty positions, including in the Department of Economics and Department of Medicine at McGill University in Canada, and the Department of Economics and Management at the Olin School of Business at Washington University, and at the University of Alabama, Birmingham, where she led the Center for Aging and Health Policy, and also served in the Department of Healthcare Organization and Policy. Interestingly, a couple of the places I just mentioned, we noted we've crossed paths. So I spent time in Canberra, Australia, and spent time at UAB, and spent time in Houston. So Dr. Ho and I, at different times mostly, have kind of crossed around the world. In 2004, she joined the faculty at Rice University, where she directed the Center for Health and Biosciences at the Baker Institute, before rising to her current position there as professor of economics and as professor of medicine also at Baylor College of Medicine. Her work has provided important insights into understanding the impact of price incentives in healthcare policy, as well as on comparative healthcare expenditures on patients with various specific conditions. For example, she has analyzed the cost effectiveness of specific levels of treatments, including, for example, statins for preventing cardiovascular disease. Her work on how the relationship of the volume of cancer surgery and mortality for procedures depends on the surgeon and the hospital has provided a better understanding of these relationships. She's also studied the differences in costs and quality of care in physician-owned versus hospital-owned organizations, as well as the financial impacts and operational implications of private equity acquisition of United States hospitals. Her research on the relationship between nonprofit hospital CEO compensation and healthcare system consolidation has added important new insights to the conversation on these interrelated dynamics. Dr. Ho has received numerous recognition and awards for her contributions. Just to name a couple, she received the Justin Kimball Patient Protection Award from Blue Cross Blue Shield, the Healthcare Advocacy Award, and she's also an elected member of the National Academy of Medicine. Please join me and welcome Dr. Vivian Ho.
Can you, so I've got the lavalier mic. You can hear me okay?
Yeah. Is that okay?
Terrific. Yeah. Thanks so much, Dr. Friedlander, for inviting me here today. It's been such a, to meet all the faculty who are working with you, I am so impressed by the work you're doing, the intellectual stature of everyone I've talked to. It's been really a pleasure to come here. So, and I'm glad that I get to give this particular talk. What I'm hoping is that if we can get some of these healthcare costs under control, then we can actually direct more funds towards the fantastic research that you and all of our scientists are doing in this country. So I'm going to talk briefly about the rise of big med, and then give you just a real simple reminder about consumer demand in healthcare, and talk about, mostly I want to spend time talking about price transparency in healthcare and what we can do with information that we learn about prices. So when I teach my class to my undergraduates every year in health economics, these are the things that the three main causes of why healthcare in the US is so expensive. And so the first is that we've got very generous health insurance coverage. You know, if your employer is paying for your health insurance and you have to go get your knee replacement done, you don't really care if you're going to a provider that's going to charge $20,000 or $15,000, because you're just going to pay the copay, the $500 copay, right? So it doesn't matter. Price doesn't matter so much into your own decision. You go to where your doctor is going to refer you to go to get your treatment. The second one is that we have fee-for-service reimbursement. So we reward healthcare providers for quantity and not quality of the service provided. It's the more you do, the more you get paid as a provider. And then the third one is the one I'm going to focus on today. Providers are consolidating into mega healthcare systems, and with that large size, they have more bargaining power relative to the insurance companies when they're negotiating the prices of care. And this is sort of, all three factors have been around, but the consolidation has really been driving the cost increase over the last couple of decades. And I hope to be able to illustrate that to you with data. So the first example here is the increase in the percentage of hospital beds that belong to a healthcare system. It's now, this stops in 2020, so it's somewhere over 80%, whereas it was not this case back in the year 2000. And so I'm going to talk about two different types of mergers that we have. The first one is the more common one that you're all familiar with, that you have a couple of hospitals that are, or more actually. It's usually, you actually have 3 or 4 hospitals in a small system that get acquired by a larger system these days. And then there's a different type. Yes, you can have physicians merging with each other, but you can also have vertical integration, which is the hospital acquiring physicians and having them work as employees for that hospital. Now, some of these slides I'm going to run through really quickly, and feel free, you can have a copy of, people can get a copy of my slides from someone here, or they can email me. Yeah, and so when we think about horizontal integration, we think generally economists think about economies of scale. You can cover your fixed costs and spread them out over a larger number of customers, and so you can reduce per unit costs, and then maybe that will translate over into savings that they could pass on to the consumer. That might be a good thing, okay? But then, as I mentioned, there's the consolidation that increases the bargaining power of the hospital relative to the insurer. So when they are larger, there's fewer alternatives for people to go shop at, and so that allows the hospital to raise their prices that they're charging to any of the insurers. And then vertical integration, you could think of cases where, because you've consolidated all these physicians and they're working on under the one hospital, then there's less chance of loss of information, there's more coordination. That could be a good thing in terms of the quality of care, less duplication of tests and things like that. But the other unfortunate thing that has happened lately is, as hospitals have acquired physician practices, the physician is still practicing out in the community in some suburban clinic, but because they belong to a hospital system now, they tack on a facility fee to the regular charge, and suddenly a patient who's been going, to get their diabetes managed for their child, this came up in the newspaper in the Houston Chronicle just the week. You bring your child in for their normal visit for their diabetes medications, and suddenly the visit is several $100s when it used to be just $45 for a copay. Okay, so that's the sort of ugly side of vertical integration. And this is a slide that you can find. It gets updated every once in a while, and it shows you, it doesn't even have the vertical integration between a hospital and a physician, but it shows you just how much purchasing has gone on between different sectors. And of course, United Healthcare, we all know that with the shooting of Brian Thompson and all the frustration, but you see what they've done is they purchased OptumRx, was a pharmacy benefit manager, which Rice used to have, and we dumped them and we moved on to a no-name pharmacy benefit manager, and apparently we're starting to save a couple of $1 million or something in terms of our pharmacy costs because of that. And then they bought up physicians as well. This is Optum Physician Services that we've got here. Okay, so some people, I've mentioned there could be cost savings because of mergers, and so that might be a good thing. And I'm not going to go through details in these particular studies, but there has been good, solid academic research showing that when these mergers have taken place, you see the dates on these studies, 2019, 2023. So we have increases in price that have been shown from these particular mergers. And by the way, insurance mergers also lead to higher costs. They don't lead to cost savings for customers. And then there's sort of the vertical integration of these two lower studies. This is one I contributed to, but you see that 6% more spending when you have this vertical integration, when you have hospitals and the physicians working under them. It's suddenly, I think what's happened is the prices have gone up for all the care that happens. And then these other two studies are a different type of merger. They are not mergers within the same market, but they're mergers within the same state. And you can ask me about that later, but in this case, this top one, double-digit increase in prices resulting from these mergers. And then what happened is, with the COVID pandemic that came along, this just accelerated the amount of mergers that were going on, both horizontal and vertical. If you've met individual physicians, this happened with more than one physician that I encountered in Houston. If you were in a small practice, your business dropped off at the start of the pandemic because everyone was too afraid to go to the doctor unless you had COVID. And fortunately in Houston, we didn't have that many people who had COVID at the start. It only got worse later. So the bottom fell out. These smaller practices, they had no other choice. They had no revenue. And so they sold out to larger physician practices, and those physician practices then sold out to hospitals that got most of the COVID relief during the first round of the federal money that came out. And there's an interesting story behind that too. So that's the story about mergers, that they've accelerated, and there is academic data showing the substantial increases in prices that have occurred. Now I'm going to pivot and I'm going to switch to talking about employer-sponsored insurance, because from this particular data, it covers about half of Americans with health insurance, and it is sort of the most expensive type of insurance. This is where a lot of the increase in costs is occurring. I'm not Medicare and Medicaid, they have lots of challenges too, but this is where I think there's a chance to get some good cost savings to the average American worker. So this is a graph that I have been, I've given public talks, throughout my entire career. And this is the common graph that I often start a number of my talks with, because it gets the point across. And so this is the cumulative, the orange line that you see is the cumulative increase in the cost of an employer-provided insurance premium to cover a family of 4 over time. And that increase is 314%, okay, through 2023. And then you think, well, at least the employer is picking up a good portion of that. The yellow line on top of it is the portion that the worker has to pay, okay, out of pocket for that health insurance. It's actually gone up by even more. It's gone by 326%. Okay, now you look at this dark blue line here, this is the average increase in workers' earnings, okay, which is 111%. So cumulative increase in insurance premiums just completely outstrips what's going on in terms of take-home pay for workers. So no wonder workers are so upset. We sit here talking about, the last election was just because of inflation. Everyone felt that inflation and the price of groceries and eggs and gas was so horrible. I'm sitting here wondering if there's this underlying thing. We don't see this price increase every day. You select your health insurance policy, at the start of the year, or for academics in the middle of the year, and then you kind of forget about it, right? It gets taken out of your paycheck and you don't think about it. You just think about your own paycheck. But I'm just thinking part of the problem with people getting by and affording things is just because this kind of stuff has dragged down on the pocketbooks of Americans. Now, so the challenge, I realized after a while, I show this slide to the audience and they conclude, curse those insurance companies. The whole problem is the insurance company is just making off with all our money, all right? And everybody has a good story to tell about terrible things that have gone on with insurers. I agree with you that. But I'm saying there is blame to go around because that increase in the insurance premium includes the cost of the underlying medical services that have to be paid for, that's why we buy the insurance in the first place. So one of my PhD students, we decided to look into this further. And what we did is we've got here price indices for hospital care in the orange. And then you'll see this ziggy dark blue line is the price index for a health insurance premium, netting out the cost of the medical services, and just looking at the cost, what an insurer does in terms of underwriting and marketing and processing claims. And then the blue line, the light blue line, is the price index for physicians. So first of all, very clear that prices of hospital services have gone up a lot. Prices of physician services have gone up, but not by as much. It's not even close. Okay, now what is going on with this insurance, these two insurance blips up and then the decrease there? So it was fortunate that we did this study last year in 2023. My PhD student, she was really good at sort of getting into regular contact with the Bureau of Labor Statistics employees while they were still there and could answer the phone. I don't know what would happen if we tried to do this now. But there was a couple of changes. So this one is COVID. So what happens is the insurance companies sold their policies and then nobody went to the doctor. Okay, there were no underlying services. So that sort of brings that price index up. And this one happened because the Bureau of Labor Statistics decided to expand and get a wider source of insurers to characterize the data, because there was this huge increase in Medicare Advantage, and they realized they weren't capturing that, and they wanted to include that price of Medicare Advantage policies into their indices. And so that was a sort of one-time broadening of their source of information. But interestingly enough, when you look at, you include, this is a one-time increase, this is COVID, and now that index has gone down to 134. Relative to the base year of 2006. That's the furthest back we could go with this price index. So if anything, the price of insurance is tracking the price of physician services. It's not the thing that's out of line. And we've checked the January numbers, and the index is still kind of down here. And we're in the process of writing that up and submitting that somewhere. So this is someone else's price index chart. This is often referred to, Mark Perry from the American Enterprise Institute came up with this, and he likes to call this the chart of the century. And I apologize again, this is why you want to get the slides for yourself, and so you can read some of this writing here. But this steepest line, and this is from the year 2000, this price index, the increase this is hospital services up here. okay? So hospital services are rising faster in prices than anything else being measured in the economy. The second line, if you're curious, is actually college tuition and fees, which, you know, we can all feel kind of uncomfortable about in the room. You know, I sit there and I tell these people I'm giving this presentation to, I'm working at the intersection of the two sectors of the economy that are most responsible for taking all the money out of the pockets of the middle class. And, you know, we could have a completely other different discussion about why that actually occurs. But then you look, wow, televisions, they drop substantially in price. We have all these, you know, big, everybody has one of these giant screen TVs in their living room, right? Cell phone services have dropped in price. And remember in the pandemic, how everyone was talking about how expensive it was to buy a car? You know, it was just the thing you really didn't want to do. Cars. Look here, here's the increase from the pandemic. It doesn't even come close to what's happened with hospital services in terms of cost. Okay, and so this is, you know, it's these simple graphs with this information. I don't think the public understands what is going on in terms of the healthcare sector. Now, the hospital sector will respond. Our prices went up because we had a massive labor shortage. We've got to pay more for our nurses and supplies and everything else, okay? So now you go into the financials of different hospitals. And what I've got here on this graph, so I've got, you know, since I'm talking to Virginia, I've got 3 Virginia hospitals here, and then I'm going to talk about the hospitals in the Texas Medical Center, the major academic hospitals in Houston. Okay, so this is Carilion Medical Center. It's not the entire system. It's just the major academic hospital here, and it's really quite good, I think, in terms of their behavior towards the public and what they're doing. So I've got 3 lines here. So this is their fund balance. This is their assets. Charity care is it's not that high here, okay? But I've got to make sure. Is it missing? Yeah. So there's a negative there, and that has to do with some accounting in terms of revenues that they received for taking care of uninsured patients. But that is just that's the medical center here, and my guess is the charity care is higher in the outlying hospitals that you've got, judging from their patient population coming in. And their profits, you know, somewhere over $400 million. Okay, so this is in contrast to sort of the Methodist Hospital, which is one of our 3 major hospitals in the Texas Medical Center. And you see their profits are higher than Carilion's. So they're providing more charity, a little bit more charity care. And their fund balance is so high that it actually goes off the chart. You know, it just doesn't even fit on the vertical axis. And when I first loaded up this data, I was just stunned. I'm, you know, $7.5 billion. What is this money going towards? Okay, and you've got larger numbers for your other two hospitals. So I had some very helpful conversations. You know, you know, like Virginia Commonwealth, VCU, they're in Richmond, right? Okay, so it's a different patient population. They have much more commercial patients. All right, so this is how they're sort of building up this higher amount of fund balance. So why does that matter? You know, and what's a good number? Well, we took this data and we looked at changes in these, you know, in charity care and profits and fund balance between 2012 and 2019. So we published this paper in Health Affairs. I have a postdoctoral scholar, Derek Jenkins, who did this analysis. And you found for a $1 increase in profit, you could find how much went to charity care and how much went to building up cash reserve, same thing as fund balance, over time. And as you can see, and these are, and this was nonprofit hospitals in the blue. So nonprofits, this is how much went to charity care, and this is how much went to building up the fund balance. Okay, so it's, you're seeing something. Yes, I understand you have to have new equipment, you have to have buildings, you have to have facilities, but my gosh, it's a nonprofit system. How much is enough? So, I think this is sort of giving you the idea of where the money that you're paying for your insurance, your commercial insurance premium, where is it going? How much is it going to really towards improving your health, and how much is going towards improving the financial standing of these consolidated healthcare systems? Okay, so basic economics. So most of you, I think, have taken an economics course at some point. So, this is the demand curve, and you have price on the vertical axis and quantity demanded on the horizontal axis. And so this is, when you have a somewhat small increase in price from P0 to P1, I've drawn an elastic demand curve. So that relatively small increase in price leads to a large decrease in the quantity demanded. So this is a customer who's very price responsive. All right, so when we have commercial health insurance, what happens is most large employers in this country self-insure. Okay, so they're paying, they pay an insurance company to negotiate prices with all of the hospitals. And so you still get the insurance card. At Rice we have Aetna, and I get an Aetna health insurance card. But Rice is paying all the claims based on that negotiated price because they're large enough and they can bear the risk. Okay, so the employer, why do they get Aetna? Why does Rice get Aetna to do this? Because Rice knows that Aetna has also gotten multiple other employers in the Houston area to sign up with them. And so Aetna can negotiate a much better price with each of the hospitals than Rice could alone. Okay, so that's why that occurs, and it's called an ASO contract, administrative services only. And so what happens whenever you have a boom in the economy, the insurers call this the war for talent. So what happens is the healthcare provider, when the economy is doing well, they'll say, hey, it's time to renegotiate the contract. It doesn't occur every year. And then, so, hospital comes and says, I want a 5% increase in all of my prices I'm charging. And so the insurer is trying to keep prices low for the employer, but the employer at the same time, when the economy is hot, they really don't want to lose workers, okay? And they're worried that if they can't negotiate a contract in Houston, they can't negotiate the contract with Houston Methodist, and employees have surgeries scheduled, there are babies that are going to be delivered, all this stuff. And then there's an article in the paper, and it's United Healthcare saying, just wanted to let you know, we're trying to negotiate this contract, and then Methodist puts its ad in the paper and says, if we don't negotiate this contract, you won't be able to get services at our hospital in 2 months or something like that. And so it's a very public war. This happens all the time. And then the HR office gets really worried. I talk with HR people about this. And at some point, the CEO sometimes will call the HR office and say, I'm getting too many complaints. Just go ahead and accept the price increase, all right? I understand it's 5% more, but we'll just go ahead and pay for all these increases in costs. What that leads to is a very different looking demand curve that your healthcare systems see. They see instead an inelastic demand curve, that they can ask for higher prices. This is the same price increase that I showed you on the previous slide, but there's a very small quantity drop. The quantity demanded only falls by a little bit. So it's as if a firm is seeing a customer with inelastic demand. So why wouldn't you raise your prices if you can always be engaging in this type of behavior? Okay, so it's just they can, these hospitals see very little drop in demand, and so this results in the higher profits that you see in the financial data from these particular hospitals. Okay, but then the problem is Rice, like many large employers, is self-insuring, and so those higher prices, they translate into a higher health insurance premium that everyone has to pay in the following year. And so that's why our premiums are going up. Okay, so one way to try and address this, price transparency, actually the regulations were first introduced under the Trump administration, the first Trump administration, and there's different regulations for hospitals that were supposed to be effective January 2021. There's details behind it. There's supposed to be machine-readable files for purchasers of healthcare and researchers like me, and then there's supposed to be these menus of shoppable services that are supposed to be consumer-friendly. And not only that, that was regulations that the hospitals had to post their prices. There are also regulations that the insurance companies have to create these machine-readable files as well of all the negotiated prices with all of the hospitals. And again, there's sort of criteria for what they have to have. So if you go to Houston Methodist, and you can go to any hospital, so the Fralin Hospital is the same thing. On the home page, there has to be a link with price transparency on it, where supposedly this data is available, okay? And so you can click on price transparency at Methodist, and you'll get to, they have multiple different hospitals. And so you can click on these, and you can get the machine-readable file. So if I clicked, this is like a couple years old, it hasn't changed much, really, because I checked it just recently. I click on the top file, it's the Texas Medical Center Hospital, and this is what you get. Okay, now some of you I know are used to reading in data like this, okay, but there's no documentation. So you don't know where one record starts and the other one ends. And you don't know if there are the same number of variables on each row. It's all a great big guess. But I was lucky, it turns out I had an undergraduate who knew that there were people in our library who could actually decode these files. And the other two Houston hospitals were not like this. And so we actually were able to compare some of these prices. And I won't dwell on these because they're really not that relevant, because even now the hospitals aren't reporting prices on every procedure. So there's very little you can tell. And actually they've made the files even worse. So it's impossible to match the same DRG or the same CPT code across 3 hospitals. It's amazing. So there's a lot of evading of the actual requirements through the government regulations. But so I was able to match up, for example, 139 services with the Blue Cross Blue Shield Texas insurance at the 3 hospitals, and then found that prices were twice as high at Houston Methodist versus St. Luke's. And then the Houston Chronicle found this was so fascinating that they put it on their front page. And then the local news picked it up, and it was all very entertaining. I can tell you those stories later. And there's now an organization, Patient Rights Advocate, which translates the JSON files, and they're in spreadsheet format there. But again, it's really hard. You can look it up, for any hospital you'd like. It's really hard to find comparisons across hospitals. Okay, so what do you do with this data? I think we will get the regulations right, so we will have it, but what do you do with this information? Because in the long run, I'm optimistic we're gonna get this information available. And I'd like to talk today about tiered networks for hospital care. And So this is just a basic illustration. I'll just put this all up. Suppose, okay, let's go back to knee replacement. And you've got 4 different hospitals, and the tier 1 hospitals, the peach colored ones, they're lower cost. And so they charge $11,000 and $14,000 for a knee replacement. Then you have tier 2 hospital, charges $15,000, and tier 3 charges $17,000. Okay, assuming now, we won't consider quality in this particular slide, but suppose an employer structures their benefit and they say, look, we've got all these hospitals, you can go to any of them, but if you go to the tier 1 hospital, your copay will only be $250. And then tier 2, $500, tier 3, $750. Okay, so all you have to do is look at your health insurance benefits. You know you're going to need to get an operation, and you can just look it up, tier 1, 2, 3. That's it. And you know the copay. Okay, currently there's no difference, right? It doesn't matter which hospital you go to in your plan. It's the same benefit, so you don't care about the price. So there was, I think this is Harvard Pilgrim Healthcare, and this is a professor at Rochester Business School now. She did this as part of her dissertation. She studied a tiered plan that was introduced by Harvard Pilgrim Healthcare over the course of 3 years, and these are the different hospitals that were included in the tiers. In terms of quality, she found no difference. There was a difference, but there was no correlation between price and quality, all right? So you could very easily, when you set these tiers, the tier 3 hospital was the highest price, but it wasn't necessarily the highest quality. So when you're sending a patient to another hospital, you may actually save them money in their copay and improve the quality of the outcomes. So these are the different copays that were introduced, the tiers, and this is what happened to patient behavior. You have to leave this in place for 2-3 years so that your employees can get used to it. They may not want to, respond or understand this in the first year of the insurance plan, but after 3 years, this is the lowest cost tier 1 hospitals. So the percentage of patients going to tier 1 increased over time, and then also the percentage going to tier 2 hospitals in the green eventually rose, and then over time, you have fewer patients going to the tier 3 hospitals. So this is a very simple price mechanism, and the patients do respond to it. And what's striking is that after 3 years, spending per hospital stay fell 8.4%. So there is a significant drop in the amount that employer is, that any employers with this plan were paying, and they increased the tier 3 copay, and then you could get a fall of 17.4% in spending. Okay, so what is going on right now is there are companies that are creating apps that have this tiered pricing as an underlying feature, as well as their measures of quality. Okay, so Surest is one of them. They're actually a component, an independent. They tell me they're independent component of United Healthcare. Okay, and so what they are doing is they've got their own measures of quality based on sort of Medicare star ratings and other things like that, and anything they can pick out from their claims. And they're telling the patients, use the app. They told them if an employer adopts this, there's no deductible, and then they vary the copay based on the provider that you pick. So it's the same particular notion. They like to, the thing that bothers me is they did an assessment, but they paid Aon to do their assessments. I'm like, what am I supposed to make about this? Is it, they say, there's 54% lower out-of-pocket costs, which just can't be right. So I'm giving this talk to employer groups, trying to convince them to adopt one of, this one, or Coop is the other company, to adopt one of these plans so that I can study it and do an independent peer-reviewed study and say, really, does this save money or not? But I'm pretty, if the underlying structure is correct, then I do think this is a way that you can get employees to be price sensitive, and we have access to the data. So to the extent that we can assess quality through claims data, I'm actually quite hopeful that we can do that as well. So just to wrap up, I hope I've convinced you that it's provider consolidation that is driving the increase in healthcare costs that we've seen over the last couple of decades, and that it's rising hospital prices that are cause for the increase in premiums that we're seeing. And I can talk more in detail about price transparency and what we need to do to get those prices really available and clear and accurate. But it's at this point, there's many things, and during Q&A, feel free, we can talk about policy. But at this point, I really do think that employers have to get involved and do their part. And most employers have not been as proactive because they just don't understand how healthcare works. But if we can get employers more price responsive in a way such that we also preserve high quality healthcare, I think we have a really good chance at trying to control healthcare costs in this country. So with that, I'd love to hear your comments and criticisms, questions, anything. Yeah.
Go ahead. Whoever had the back there. Sorry. Anthony, go ahead.
Is it possible, though, that if you ask employers to actually be price sensitive, that they're actually going to take that as an opportunity to try to shift costs to public options like the ACA, the insurance markets, and then that will drive care quality down because hospitals aren't being compensated as they were, and also there's not another option. So I can see a bad incentive here that would actually cause a distortion in the delivery of care and also in the employee satisfaction.
Yeah. So yeah, whenever we're making changes like this, you're always worried about the unintended consequence. So what you were saying, are you saying that the employee is not going to be happy about this and then they're going to try and leave?
The employer, if they can't find an alternative, they may simply say, we're not going to provide this as a benefit, and either return some of the money in earnings, but then you'd be on your own to either work through the marketplace, particularly small employers who are kind of in the middle.
Yeah, okay, so if we stick with the current system, that's what we're having. You're right, we're having the small employers saying, I can't afford health insurance, and so I'm just not gonna offer it anymore and take the hit in terms of the quality of employees that you can attract. This gives an option to an employer to try and avoid that and say, look, I'm gonna provide you a benefit, but we're gonna hold down our hospital expenditures. And so that's a way to actually preserve employer-provided health insurance.
Go ahead. Yeah, Paul.
Hi. Okay. Thank you. So two questions. Everything you presented is certainly internally consistent and well understood. Two questions that come up are sort of to look at some other perspectives, perhaps. Much of the third-party payer, employer-based insurance costs, the absolute numbers, are driven by the low reimbursements from Medicare and Medicaid. And the hospitals, one way to say it in common parlance, is they have to make up for those deficits, if you will. So if you could speak to that. And the second question is, in terms of the health insurance companies, I saw a recent statistic. The insurance companies are making multi-billion dollars of profit. 95% of that profit is going to their shareholders. And almost none of it is coming back into our healthcare system. So if you could comment on those 2 points.
Yeah, sure. Those are two great questions. So on the first one, and by the way, we've had some good discussions about this. There's a lot of heterogeneity in these numbers. So even though I'm showing you something about profit margins for hospitals and how high they are, I really do think it's the large consolidated systems. And so each of these systems in Houston that I showed you are much larger than what you have here. And actually, so for example, Carilion is not a problem hospital, in particular because, as I understand it, you say more than 70% of your patients are Medicare and Medicaid. So you know, there needs to be more studies about the heterogeneity. I really think sort of the larger systems are actually making things worse for all the other healthcare systems. Now, so in terms of losing money on Medicare and Medicaid, this data, I worked with it's the National Academy for State Health Policy, NASHP. It's their hospital cost tool. You can access this on the web for free. And it was all the formulas were created by a forensic accountant who worked for the state of Montana. She was supposed to be buying health insurance for the Montana employees. And she went to the Montana hospitals and said, your price increases are too high. And they said, oh, you know, we have these Medicaid and Medicare patients that we're losing money on. So she said, all right, I'll go get the Medicare cost report data. And when she pulled it out, she found in most cases they were actually not losing money on Medicare and Medicaid. So that's why this hospital cost tool is created. You can get much more detail. You can see whether a hospital is losing money on its Medicare and Medicaid patients or not. And it'll also show you, it calculates a number and says, this is what the commercial prices would have to be in order for this hospital to break even. And they're substantially lower than the actual commercial prices, which the hospital cost tool gets from a survey called RAND 5.0. So, you know, I'm sympathetic to hospitals that have a large Medicaid population. In certain cases, you know, for example, like Carilion, I'm not sympathetic to many of these other cases who particularly meth, you know, and MD Anderson, I didn't show you that number. It's kind of like their fund balance is like $13 billion and they rarely take care of a Texas Medicaid patient. So, you know, where's that coming from? And it's like it's a Texas institution. Okay, so the second question you had was on the insurance companies. So if you look at the paper that has the price indices, it was a very short format paper, but in the appendix, we graphed the profit margins from insurance companies, which is from the NAIC, the National Association of Insurance Commissioners, and we compared them to the profit margins of hospitals from the hospital cost tool. And in every year except one, the profit margins for the hospitals exceeded those for the insurers. So while that money is going to shareholders, those margins are lower for insurers than they are for hospitals. And yeah, and again, that doesn't get insurers off the hook. There's plenty of, I could tell you all sorts of things that they do, but I'm sort of going after the biggest fish right now, and I really am convinced that it's the large consolidated systems.
I have a question online, I'll read if I could from someone. It says, in rural areas or places where access to medical specialty care is challenging or almost non-existent, how can we advocate for ensuring that price gouging is not taking place as there is little competition to keep pricing in check?
Yeah, so rural hospitals face this completely different challenge that I cannot address with this particular proposal, and I'm completely sympathetic to that. I think in those cases we have to be more thoughtful about maybe introducing price regulations, price caps. So there are some people who are talking about, you know, commercial prices are out of control. Let's just cap commercial prices at 200% of Medicare, or even 300% of Medicare. And there's just, for other reasons, I just don't think that's politically achievable. But I think we might be able to make that case for rural, because everyone agrees that that is a low-income population. They don't have the resources. If we want to preserve a rural way of life in this country, and I think there's good reasons why we want these these people living out in these areas, there, I think, we should consider some sort of capping of the prices.
Yeah, go ahead.
You mentioned early
So the
on,
people online can hear you.
you mentioned early on the fee-for-service system in a derogatory way. I can agree. I run a primary care group of 40 providers, and independent, it's not a viable business under the fee-for-service system. And we'd be happy to take risk in a significant way, but the payers are not offering reasonable deals. So can you talk about what you're seeing in it would seem to be a much more collaborative arrangement between providers and payers if there was a significant risk shift where they really had to manage the cost and quality together?
Yeah, that's been this big puzzle. Sort of economists came up with the notion of value-based care, and they thought, oh, this is going to take over the whole industry in the matter of 20 years, and it hasn't happened. I don't have a good answer to that, except I just feel there aren't enough incentives for insurers to do that vis-a-vis the providers. And you're gonna see a large provider is making a ton of money off of fee-for-service, so they don't want to switch. And it's sort of what the larger group of providers want that's going to drive the whole system.
Every physician that any health system owns, I think they tell you that their deficit is somewhere between, I don't know, $75,000 and $200,000 per doctor per year. So they're not making money off the physician enterprise. And that, I think, is driven by the CMS fee-for-service reimbursements, I think.
Yeah, and you know more than anybody else, primary care is under reimbursed relative to the specialists because of the way the RUC committee is created by CMS. And so it's the way it's stacked. The specialists are always going to vote for higher prices for their services, and you're always going to get under reimbursed. I'm kind of hoping, and I don't know if RFK is going to figure this out because he's too busy, trying to attack vaccines. If he understood the RUC, the best thing he could do is just walk in there and get rid of it and reset the administrative prices and say, okay, we're just going to raise the prices for primary care by 25%, and we're going to lower the prices for specialty care by 25%. And, then you would have more physicians choosing to go into primary care, and that would change this. It's still fee-for-service, but, at least we're sort of getting more of the type of care that we hopefully is better for the patient in the long run. Yeah, it's a tough question. I don't have the full answer.
Yeah.
You mentioned this briefly, but a system like Carillion, 30% of their patients are commercial patients, and they represent more than 100% of their operating profit. And you've heard a couple of times here that it seems to be very difficult to drive these value-based programs that, or to negotiate better fees with the hospitals. But the other alternative is to invest in ways to keep people out of the hospitals. Medicare is not doing a great job of it, but there's an enormous incentive on the commercial side. So I'm curious, one, of what you're seeing in that realm as far as employers getting involved and being able to make a little bit more intelligent decisions around investing in preventative care, and then secondarily, for a place like Carillion, those 30% of their patients are worth 3x, 4x the other time. If you see a 10% or 15% reduction, and even this gets into procedures and diagnoses, specific procedures and things that are driving the majority of the profit there. What does that speak to financial stability for some of these systems that may look strong from a balance sheet or an income statement perspective at the whole, but when you drill down, they're relying very, very heavily on a very, very narrow foundation?
Yeah, good question. So does anyone work in an HR office here? If you meet these people, they're not, the range of tasks that they have to deal with is enormous because, they're dealing with onboarding and offboarding. They're dealing with problem employees, that they have to get rid of, which are, just a huge amount of time and all these other benefits. And so, and most of them did not major in economics. And didn't even know they were going to go into human resources when they went to college. And so they are ill-equipped to deal with any of this. And so if you present them, how about coming up with things that keep your employees out of, buying additional things to keep your employees, out of the hospital and things like that. And if you go to a consulting conference, you'll see there are all these extra vendors. There's like 20 or 30 of them, and they're all giving away free stuff and saying, buy my third-party app that's going to save you money. And so and then they just all have, there's no randomized controlled trials showing that anything that they sell works. But then the HR people, they'll sign up for this stuff and throw money at it, hoping it works, and it'll be like $20 per member per month, and they collect their money. So it's just, I just wish CEOs would think more carefully about this. Mark Cuban is really good and intelligent, and he's gotten involved and he's working on these things. So it's just the standard large American company is really bad at doing what you want. And also what they're thinking is, okay, if I lower your cholesterol and reduce your cardiovascular risk, that's going to keep you from dying 20 or 30 years from now, but you're not going to be my employee, so why should I invest in that? So, that's the other thing. And in terms of these hospitals relying on this small portion of their patients for their financial base, it's hard, I agree, it's hard to run a hospital. I'm not sure, I've written, this paper showing that the CEOs who got paid the largest increases over the, course 2012 to 2019 were the ones that increased the profit of their system the most and the bed size. Okay, so the boards who are responsible, it's the board that's supposed to be designing the incentives of the CEO, and they're incentivizing them to consolidate. And it's like, what, why is this happening? So I'm hoping that there can be a dialogue and communities sort of talk to these boards and say, what are you doing? But I don't know.
So we have one more, be a last question, I guess, online that I'll read out. I understand the need for patient privacy, but in the explanation of benefits, all I've ever seen is lab. But the actual test is not listed, just a price, what the insurance covered and what I owe. How can one request the actual specific lab costs so one is able to determine or negotiate with what lab work may cost at another entity that provides the same service?
Oh gosh, yeah. I try to do this myself, and I completely sympathize with whoever asked that question. If we get the price transparency regulations right, so currently, I think CMS dropped the ball on all of this. So they have this website on, up, and it says, 70% of hospitals are compliant with the regulations. Yeah, they posted something, but it's garbage. But if we get the regulations right, you'll get everything, including the cost of lab tests. And that was supposed to be that consumer-friendly file that's supposed to be available for every hospital. It would have there were 75 services that were supposed to be comparable, the same services across every single hospital, and they can pick the other 225. But, I asked my interns and research assistants, can you find this file? This consumer-friendly file that's supposed to be there for hospitals? Like, I can't find it. So we're not there yet, and we should be pressing harder saying, look, there were laws passed, this is supposed to be up, where is it?
Please join me in thanking Dr. Ho.